Welcome everyone to our latest NCRED webinar. I'm going to just start right off by handing over to Raechel, who's kindly agreed to chair this session today. If you want to introduce yourself, Raechel, and get going with the panel, I'm extremely grateful to everyone who's here today. I think it's going to be a really super session. So over to you, Raechel.
Thank you, Nadine. I want to say good afternoon all and good morning to the people who are joining us from the southern states. And welcome to the NCRED webinar today, Digital Interventions for First Nations People. Before I start, I'd like to acknowledge the traditional owners of the lands of where I'm meeting today. I'm on the lands of the Wadi people of the Darwin language group. I'd like to extend my acknowledgement to the lands that everyone's joining us from today. I'd like to pay my respects to the elders, both past and present, and I'd like to acknowledge our continuing spiritual connection to land, seas, skies, waterways, and these lands were never ceded. I'd also like to extend my acknowledgement to all the First Nations people who are joining us today. So Nangawi, my name is Raechel Wallace. I'm a proud Wadi and Wandywadian woman from the Yuin Nation on the south coast of New South Wales. I'm also the Aboriginal Program Manager at NADA, and I'm going to be your host today. So I'm going to start by introducing all our fabulous presenters, and I will start with Raechel. Raechel Wallace. Sorry, Raechel. Reilly is a health psychologist and a senior researcher in the, and I hope I pronounced this correctly, Warralong. Oh, I can't pronounce it.
Karinga, that's okay.
Thank you. Aboriginal Health Equity Theme at South Australian Health and Medical Research Institute. Her current research focuses on anti-racism and health in health and community settings, and exploring how primary healthcare services can meet the mental health and social and emotional well-being needs of young people. We also have Professor Scott Wilson joining us today. Professor Scott is the CEO of the Aboriginal Drug and Alcohol Council in South Australia and an adjunct professor in the Centre of Alcohol and Policy and Research at La Trobe University. He's the lead convener of SAHMRI, South Australian Aboriginal Community Controlled Organisation Network. Scott was the co-director of the Centre of Research Excellence in Indigenous Health and Alcohol. Scott has worked in Indigenous communities nationally to develop innovative ways to prevent, treat, and reduce harms from alcohol and other drug use. We also have Wendy Williams with us today. Wendy Williams works as an Aboriginal health worker at St. Vincent's Hospital, Sydney Drug and Alcohol Service, supporting clients with substance use issues in both inpatient and outpatient settings. She builds rapport with clients using motivational interviewing techniques and educates them on available resources and support systems. Her role also involves guiding clients through the healthcare system to improve access to culturally safe services for Aboriginal and Torres Strait Islander peoples in the Darlinghurst area in Sydney. I'd also like to note that James Ward is unable to join us today. I'm going to now hand it over to Raechel. Thank you, Raechel.
No worries, I'll just share my screen. Did I share the right screen? Everyone see that okay? Is that slideshow?
Yep.
Yes.
Great, thank you. Thanks, Raechel, and thanks everyone for having me here today. It's great to be invited along by NCRED, and it's great to be able to talk about this project, especially alongside Wendy and Scott, who are true experts in this area. Before I get into it, I'd like to acknowledge that I'm joining you from Kaurna country, and I pay my respects to elders past and present. I'd also like to acknowledge the cultural authority of the Aboriginal and Torres Strait Islander people who are joining from other areas today. Also, thanks to James for entrusting me with the task of presenting here today. He does send his apologies. He's got the flu. I would just like to note that the presentation contains the image of a person who's passed away, and that image is used with the permission of his family. This work obviously involves the work of a lot of wonderful people. So whenever I'm talking about it, I'm representing the work of a big team who worked for several years on this project. James managed to get together a pretty amazing group of experts in alcohol and drug treatment and research, and I'm really grateful for all the incredible things I learned along the way. So just to give you a bit of background into Wadawanti, which is the web app that we're going to talk about today, it was an output from a larger research project called Novel Interventions to Address Methamphetamine Use in Aboriginal and Torres Strait Islander Communities. This was a partnership between 10 Aboriginal community-controlled health organisations nationally. It was funded by the NHMRC back in 2016, and it continued through to 2022, 2023 because of all the COVID years, delays and things. We also had some funding from NCRED to do some later phases of the evaluation, which is really fantastic. So the overall project had 4 phases. The first 2 phases were about collecting qualitative and quantitative information, which was then used to inform the second, more action-based phases of the research, developing community-led interventions, so prevention approaches, and the web app, the Wadawanti that I'm going to talk about today. So I will talk a little bit about the results of those earlier phases, and then I'll move on to talking about the web app itself. So the first thing we did was a cross-sectional survey, which was a national survey of people who had used methamphetamine in the last 12 months. It was self-administered and anonymous. We employed community-based researchers to implement the research on the ground in their own communities. And we also used peer recruitment in this survey. So in the end, we had 734 participants who had used methamphetamine in the past 12 months. They were aged 16 and over. Nearly 60% of the participants were Aboriginal and Torres Strait Islander, which we were really pleased, as the purpose of the survey was to understand their experiences. And we found that the Aboriginal and Torres Strait Islander and the non-Indigenous participants weren't significantly different on most of the variables that we measured, but we did find that there were some psychosocial differences in the context of use. So some of the differences were that Aboriginal and Torres Strait Islander participants felt less able to access healthcare, including mental health services. They were less likely to report a mental health diagnosis, and they were more likely to turn to family support for support. They were also more likely to be living with their families. And by contrast, non-Indigenous participants were more likely to be living alone. So of relevance also to this project was that more than 90% of the Aboriginal and Torres Strait Islander participants said they had a mobile phone, and more than 80% of those regularly accessed the internet on their phone. So in order to take a bit of a deeper dive into some of the issues around the context of methamphetamine use, we conducted focus groups and interviews in 8 of our partner sites. We spoke with almost 150 people across 3 groups: service providers, people with experience of use, and community or family members of people who are using methamphetamine. We explored risk and protective factors, and these were identified across multiple ecological domains. And you can see some of those domains in the poster that's depicted on the slide there. This is one of the resources that was developed as part of the project. So some of the key messages that came out really of both phases of the qualitative and quantitative phases of the research were that the needs of families were really important. Families were playing a key role in the lives of people who are using methamphetamine, providing all sorts of supports, practical support, logistical, maintaining connection to community and culture, but often their own needs, the needs of the families themselves, weren't really addressed. The other key messages were that complex trauma, grief and sorrow, worry for family, and experiences of racism were considered important risk factors for methamphetamine use, and connection to culture and community were important protective factors that may not be considered in mainstream health promotion frameworks. So thinking about moving on to the development of the web app itself. So we took the findings of those first 2 phases that fed into the early development, and we hoped that the web app would fill in some of the gaps that are identified in available services, where there were barriers to access, such as geographical distance or stigma. And the development of the app involved an iterative process of consultations with many different groups. We had a clinical advisory group advising us on the key components of a treatment program for methamphetamine. We had cultural advisors who advised on the appropriate way to present that information in a culturally appropriate way. The community-based researchers, the site coordinator group, also played a really key role in that. The investigator group, of course, and then we consulted with several groups of people with experience of methamphetamine use, whose feedback was obviously critical to ensuring the app was relevant and appropriate for them. So once developed, the web app, which at that stage was called We Can Do This, was subjected to an RCT, a randomised controlled trial, and a qualitative evaluation that I'll talk about a little bit later. There was a documentary exploration and further review, and then we ended up with a name change and a revised, hopefully improved web app called Wadawanti, Leave the Ice Alone. And Wadawanti is Pitjantjatjara Anangu slang for leave the ice alone. So along the way, we had more questions to address, like what do services need to be able to incorporate digital tools into their practice? What supports are required to enable their use, and how can digital interventions be sustained over the longer term? And one of the ways that we sought to explore that was through a film-based research project, which explores how the web app can be incorporated into the day-to-day operations of a alcohol and other drug service on Bangala country in South Australia. The link down the bottom there is to a YouTube clip that summarises that project, and it's also on the landing page of the web app, which I'll give the link to at the end. So there's still questions that we're grappling with, in fact, as time goes on. So what did we end up with? Well, Wadawanti has 7 activity-based modules. They're based around cognitive behavioural therapy. So there are some activities that seek to explore the importance of living without methamphetamine, use a little bit of use of motivational interviewing and decisional balance, some activities that explore how to build confidence in living without methamphetamine, avoiding avoidable triggers, anticipating triggers, managing triggers, coping with cravings, coping with difficult emotions. There's in the slowing down module there's some cultural reflections and some activities looking at working through grief. Rosemary Wanganeen had some input in that section. There's also some mindfulness exercises, so to help with emotional regulation and relaxation. And there's a module there based on acceptance commitment therapy, which is about identifying and understanding your values and setting some goals to move towards those values. Throughout the app, there are films embedded, which are a way of hopefully making the content relevant. We employed actors who depicted those stories. The scripts themselves were based on real stories that we collected from people through the qualitative interviews and through interviews that we did specifically for this purpose. So we had 4 characters in the end. Clinton, who's looking back on his experience from, that occurred some time ago. Tanisha, who's starting to identify that methamphetamine might be becoming a bit of an issue for her. Joshua, who doesn't think his meth use is an issue actually at all, but you can see that it's having an effect on him in certain ways. And then Auntie Rosie gives the family perspective. So I wanted to give you a little taste of one of those videos, and hopefully the sound will work, and I trust someone will let me know if not. No sound? No?
No.
No sound. That's okay. That's all right. We'll skip over. The videos are in the app, so if you take the time to have a look at Wadawanti itself, you'll be able to come across all those videos. Okay, so as mentioned, we subjected the app to a randomised waitlist controlled trial. This was for Aboriginal and Torres Strait Islander people who reported using methamphetamine recently. We measured frequency of use and various other variables at baseline, 1 month, 3 months, and 6 months. And in the end, we found that all the participants reduced their methamphetamine use, which was good, I guess, but there was no significant difference between the intervention and control groups. So the biggest barrier to the trial or to the use of the app was retention. So we found that lots of people signed up, logged on, had a look around, but then didn't log on again. And this is a really common problem for web apps. And it was despite automated reminders and lots of prompting from the research team. Encouragingly, though, we did find that when we looked just at those people who had logged on more than once, so had better engagement with the app, they did, in fact, significantly reduce their methamphetamine use compared to the control group. And there is a publication if you're wanting to have a look at that. But the other part of the evaluation was a qualitative evaluation within health services, so in a more supported environment. So the app was used in primary healthcare services and alcohol and other drug services. And when we spoke to clients and providers, they provided feedback which was encouraging and seemed to suggest that this was probably a really appropriate place for the web app to be used. So you can see some of the quotes on the screen there. So what some of the clients said: it helped when I was craving, it helped at a time when I didn't have a support person to turn to, which was really what we were hoping, that it would fill that, fill some of those gaps. I felt really safe to be open and honest on there, which was good. Another client liked to see the comments and or the experiences of other people, which is really talking about the films that we just mentioned. So really sort of collectivizing the experience, I guess, of reducing that stigma. And then the providers, one said that they had a good feeling about it. They found it user-friendly. And often they were using it either in the counselling session itself, so going through the activities together, or it was something that they could give to clients to take away and use, as homework, if you like. There is a publication on that one as well. So to sum up, found overall that the web app, through the feedback on both aspects of the evaluation, it was considered coherent, it was relatable, empowering, culturally safe. People valued the flexibility and noted that it did reduce the stigma that they sometimes felt in looking for help in other ways. People liked the videos, and there was they also liked that they could store some of the data from the modules that they completed as a PDF or a printable summary. And so ultimately we concluded that Wattawanti could be useful in a supported context. So it could provide a useful entry point for clinicians to start conversations, to break down stigma, to normalise some of the challenges experienced by people who use methamphetamine, and then guide them towards making positive change in their lives. So what now? Well, we've created a clinician guide in acknowledgement of the fact that we think that in a clinician-led or supported context, that's the best use for this resource. It's available in hard copy, so you can contact me by NCRED if you'd like a copy. It is also, though, available within the app, so there's one of those tiles is actually the clinician guide. We're constantly seeking feedback, so there is a feedback button within the app, so for people can let us know something's not working or there's a bug or just a suggestion for better use. We're adding resources to the healing circle and to the slowing down segment, which contains a whole lot of videos and stories and cultural reflections and things like that. Currently, the app is housed at SAHMRI, but we are looking and in conversations about where it will sit in the longer term. So thank you. That's it from me. I'll hand over to Scott.
Thank you, Raechel, for that. I was just wondering, to the NCRED team, is there a possibility that we can play that video not in the presentation, like how we got it going before the webinar at all? No? Because we did get it going. That's all. I was just wondering.
Yeah, if Raechel wants to pull it up outside of the PowerPoint, I think that's fine.
Did you want to show it, Raechel?
Do you want to do that at the end? Maybe we can let Scott go.
All right.
We can sort of.
Welcome, Scott. You're on mute. Oh, you're on mute, Scott.
You can hear me?
Yeah, we can hear you. Thank you, Scott.
Okay. Thanks a lot for inviting me along to this webinar today. I'd like to acknowledge the Gadigal people of the Eora Nation as the traditional custodians of the land where NCRED is located. I'd also like to mention that I'm actually coming to people from Ghana land here in Adelaide and pay my respects to their elders past, present and emerging. Unfortunately, Kylie was going to present with me, but due to personal family reasons, she couldn't be here today. We'd also like to acknowledge our partners that are involved. Why can't I go to the next screen? Yeah, so, and some of the people that are involved, obviously that's me a little bit younger ago, because people, we'd also like to acknowledge the National Health and Medical Research Council, who gave us the grant, study investigators. Some of these people, Professor Kate Conograve, Jimmy and Lynette, who are the voiceover people for the actual GROG app. It's interesting, isn't it, that we're having a webinar on digital innovation in Indigenous communities when people might think that, you know, these sort of technologies have been around for a long time, when in actual fact they haven't, right? This is all new sort of stuff. Like I recall that we come up with the idea of the GROG app in 2012 when digital phones and things like that were just coming into the fray. And if you think about it, webinars such as what we're having now really have only been around for the last couple of years since the pandemic with COVID. Prior to that, you had to be a major big corporation before you could do things like video conferencing. So it is all new. So we came up with the idea at the 2012 about, because Aboriginal people are big uptakers of digital technology, whether it was mobile phones or etc. And one of the things that we sort of thought we could do was maybe digitalise the National Drug Strategy Household Survey, because we know that the household survey isn't as accurate as it should be. For example, it underreports women's consumption patterns, you know, quite dramatically. And so what we thought we would do is actually start with something easy, and we thought we'd sort of pick alcohol. And so we called the app the GROG app, because for some people it is quite tricky to talk, ask people about drinking and also drug use. And so, as I said, surveys don't match what people were seeing on the ground, but unfortunately are used to inform funding. One just has to look at when we knew that methamphetamine, for example, was becoming a major issue here in Adelaide, for example, as well as around the country. The government really didn't do anything, because the National Drug Household Survey was saying that less than 3% at that time were using methamphetamine. So there wasn't a lot of funding until roughly Malcolm Turnbull in 2015-16 poured in hundreds of millions of dollars. By that stage, unfortunately, methamphetamine usage has taken its hold, not just in capital cities, but rural and remote communities around Australia. So we started, like I said, about 10 years ago, we started planning this work to make it a lot easier. And basically, we want to try and find a better way. The GROG app, as I said, has been around now for a couple of years. Bit similar to what Raechel was talking. You know, we obviously had to design the GROG app. We chose the iPad as a platform. We then had to go out, obviously sit down with people from around the country, because it has to work nationally, not just in South Australia, for example. And then we had to do, you know, trial testing in rural, remote and urban settings. And then, you know, prevalence study, et cetera, et cetera. For example, when we were doing the prevalence study in one council region, we actually ended up surveying 30% of the Aboriginal population, over 750 people that lived in that council region. So, and also at the same time that we were doing it here, we were also doing it nationally. So we know that it actually does work. We've probably published on the GROG app in various publications, whether it's Drug and Alcohol Review or a range of others, about 30 times now, that we've had publications in peer-reviewed journals. It obviously suits Aboriginal and Torres Strait Islander people, 16 and up. It has to be urban and remote. It's in English, and we chose Pitjantjatjara language, so it's in Pitjantjatjara language as well. And it's adaptable, that we can adapt it for anybody's language. It's in male and female, so when you come onto the app, it asks you what gender you might be, and as soon as you sort of say that, then the whole imagery will change to either male or female. It does work offline. Initially, we were using it as a research tool. For example, if you were thinking of doing an alcohol intervention, just for argument's sake, in Alice Springs, we could come in and use the GROG app, find out what the patterns of use were. You could bring in your intervention. Halfway through that intervention cycle, we could redo the GROG app. And basically, if consumption hasn't gone down, then there's something wrong with the intervention, and you don't have to wait until you finish the intervention and a couple of years later you do an evaluation and work out that the intervention didn't work. You could do that almost as you're going. All of the information was being uploaded to Sydney University's secure servers, so that it is highly confidential. People's information and data are secure. The results are comparable with existing surveys and screening tools. We also modified Visual Audit C is included. And at the end, you can also generate infographic de-identified reports. Now, this is just giving you what the screen looks like if you're a female. And this they've chosen English as their language. What we did is we tried to build in there sort of prompts for people to remember. So, for example, this one asked people, okay, have you had any grog or alcohol at all in the last 12 months? For example, since the AFL or the NRL grand final, which, a lot of people can actually sort of base that and sort of basically, so we just are checking, making sure that people, you sort of said that, it was you had alcohol at that period. Are there other special events that you might have liked, had alcohol, such as carnivals, weddings or funerals, and things like that? To make sure that we're sort of putting people where the place might be, we've tried to include everywhere that we can think of that people might actually be drinking, whether it's at home, out in the bush, park bench in a hotel, club or a restaurant, because people aren't sort of, people do drink quite often in a whole range of different settings, and we wanted to make sure that we captured that. We also, you can see there's a little hand sort of thing. That's a slider that you can sort of move along, because the whole app is touch screen, so you can touch all of these screens, and like I said, it's highly interactive. So we want to know how many people you might actually be drinking with when you're sitting down and having a drink. And you can slide that up or down to sort of reflect how many people you might be drinking. We have nearly every alcohol product you can think of imaginable, because like I said, it has to be national. So we couldn't just have West End draft beer, which is South Australian specific. Well, not anymore because they shut down the brewery. But so once you pick what it is, the alcohol that you might be drinking, like I said, beer, wine, port, spirits, etc. We then also ask you, well, okay, what are you drinking? When you drink, what are you drinking out of? Because not everyone is drinking out of, pub size glasses, etc. And what we find is a lot of people, particularly in rural and remote communities, or even in the cities, are drinking out of a variety of different containers, such as, mannequins, or in this case here, a Mount Franklin water bottle. And it is interesting to sort of ask people what they might be drinking out. I'll just give you a quick story. I know of a clinician who saw a client coming in and out, was asking them about their drinking. They sort of said that they were drinking 2 drinks whenever they drank. So they thought, okay, yeah, right, that's within the standard alcohol guidelines. But next time they saw them, they noticed they were a bit wonky, i.e. a bit drunk. And they asked them what they were drinking out. In actual fact, they were drinking out of, 2 600 ml water bottles. So it is important that you sort of try and work out what the container might be. Again, the little hand slides up because we say, okay, well, when you drink, how full might that container be? So they can raise it up or down. And there's a reason for that, because we don't actually ask people about how many standard drinks they might be drinking, because a lot of people might not necessarily know what a standard drink is to start off with. So once we know what the alcohol they might be drinking, what container they're actually drinking out of, and how full that container is when they're drinking, the app will automatically calculate that into standard drinks anyway. So there is like I said, so we basically, need to do that. We also need to find out, as you might know, that a lot of Aboriginal folk don't necessarily just drink in individuals. They do group, in particular, might be drinking in a group setting. So we need to find out, okay, when you drink, is that just you drinking that amount, or are you actually drinking with other people? And once they confirm that, we can sort of say, well, okay, for example, if me and Kylie went halves in a car, so I selected a 750 ml bottle, a screen pops up and asks you about that. So basically enters that, when I'm drinking, I might be drinking roughly about 7 standards of drinks. So for some people, it'll ask you, they don't drink at all, but it's interesting when we're actually asking people that, so you'd automatically put them down as a non-drinker. But if you actually, the app will ask them more other questions, and it turns out that, for example, we come across quite a few that might only drink on one occasion, i.e. it might be only their birthday once a year, right? So the app is quite clear about, making sure that we can actually get a complete picture around people's drinking. Each person who does the app gets a tailored feedback, i.e. a brief intervention. So once they've completed the app, which only takes, roughly about 10 minutes to complete, it'll actually give them the pyramid that sort of says, okay, based on the questions that you've answered through the app, you might be drinking at a high risk level. It'll then sort of give people tips on what they might, if they want to cut down. So they can click on each one of these icons that do pop up, and gives them a whole range of tips that they might want to do to cut down. It also talks about trying to alcohol, you know, does affect the brain, and things like did you know that thiamine, you know, that if you took thiamine, for example, that might actually protect your brain from things like alcohol-related dementia and things like that, and get people to sort of talk to their health worker and that about things like that. So one of the things that we've then sort of moved onto is not only have we you know, adapted now the GROG app, for example, for use in women's and children's antenatal classes, or when you're pregnant. We've adapted that for women's and children's here in Adelaide with the Corker Mums and Bubs program. They wanted to ask us to sort of put in questions about cannabis use as well, so we were able to do that. We're now in the process of adapting the GROG app for use in not just in primary health, because if you're going in to see a doctor, they just want to get maybe an A4 sheet of paper that sort of gives a quick pictorial on that person's drinking, which might actually prompt the doctor to start asking questions about people's alcohol consumption. Because, you know, if you go to a doctor, more than likely they're going to ask you about, do you smoke? But they're not necessarily going to ask you about, do you drink? Because whether that's a bias from doctors who might be drinking themselves. And so we've come up and we're adapting it for use in primary health and also to be used in mental health. We also then got another grant through NHMRC, and we're just in the prevalence stage at the moment. It's called the drug app. We're thinking of coming up with a different name, but it basically goes along the same lines in the fact that it's touch screen, and you know, again, it'll be male, female, etc., and in language. And for example, it'll ask you the question, you know, have you smoked in the last 12 months? And basically, it'll give you a whole range of, if you say yes, it'll give you a whole range of things on what you might have smoked that you can sort of click on. So, for example, in this case, the person sort of must have said that they'd smoked cannabis. So then we'll ask, well, okay, you know, how do you use Yandi or Gunja, as people might call it? Are you smoking it in a bong or a pipe or a joint or other? So it, like I said, highly pictorial. It might then sort of tell you that, you know, what that might mean for you. Again, it's captured, it's convenient tool. As I said, we're just in the prevalence process of the drug app at the moment, where we're trialing, and also because we have to get X amount of people from different age groups, for example, in rural, remote, urban. We have to try and capture people that might be using regular, so therefore dependent on, let's say, methamphetamine, down to those people who might only use occasionally, i.e., you know, on a Saturday night, for example. And that, I suppose, it's that last group that is finding it a little bit harder for us to sort of get, because trust me, we have no problem with people coming up to do, whether it's the GROG app or whether it's to do the drug app, because I think it's about the fact that somebody's sitting down and actually, you know, interested enough to ask you about your story, that most people who use substances tend to be very willing to share. Part of the issue also is to make sure that the questions that we ask through the GROG app are accurate enough. When we were doing the testing trial phase, not only did people go and use the grog app, for example, they then went and sat down with a clinician who then basically asked the same questions to sort of work out, were the information that we're getting from the app itself, was it as similar or as accurate as it was for, you know, face-to-face actually asking questions. We actually believe through the research and through using it now for quite some time, that obviously people feel more comfortable in using the app because it is confidential. As I said, you know, you could be just sitting there while you're waiting at the doctor's clinic, you know, watching a movie for all anyone else knows, because these days people are always either on some form of technology, whether it's a phone or whether it's an iPad. So, as I said, we had no problems getting people to use it. We can modify the whatever we want to do with the app, because we have total control of the hardware, so to speak. And, you know, between ADAC and in Sydney Uni and La Trobe, we actually you know, have the IP, intellectual property, and the copyright vested in those three organisations as well. So, like I said, it started out as a community survey tool, and now we're looking at it being a screening tool for primary care, antenatal, and, you know, in a whole range of other settings as we move forward. If you've got any questions, I suppose, you know, Raechel will facilitate that. But thanks for having us. And if you wanted to, if anyone wants a copy, because we're trying to come up with a really flash name that we can sort of call, for example, the grog app, that we can then put in on the App Store so that people can download it if they just want to check their own drinking, or once we've got the drug app, if they want to see where they fit in the drug cycle. You can email to Kylie Lee, and her email address is there, or to Leah Reynolds at La Trobe as well. They'll send you a link. And it's interesting, one of the things that we sort of learned, I suppose, because it is about learnings, is from the grog app to the drug app. When we first did the grog app, we just assumed, you know, being naive, we just assumed that once we put it on an iPad, it'd work for anything. Well, you know, we then found out that it didn't work on a, you know, an Android system. So now when we did started with the drug app, we made sure that regardless of whether you got an Android type technology or Apple type technology, it'll work on either any platform at all. So, like I said, thanks for having me, and I could talk all day about these apps, because I think they're the way to go in terms of giving our clients anyway a bit more sort of control over the information that they want and what they want to share with people. So thanks a lot.
Thank you, Scott. And also, I could listen to you speak all day. So, yeah, thank you. We brought the panel together. Thank you for presenting on both those two really good apps, because I can remember back when the Wadi Wanti app was getting developed, you know, and that was only available in pilot sites in the beginning. And, you know, I was harassing one of those pilot sites, like, when can we get access to this app? So, and I think that's in one of the questions as well. And also, I know how long the grog app has been in the making. And Scott, I just wanted to ask, that's now available to everyone now. I know there's a lot of work still going on making it, you know, for mums and bubs and in the primary healthcare setting, but is that available for drug and alcohol workers across the sector? Because it is really good, because as you said, the measurements of the drinks, you know, because, you know, our mob can go in and say we only have 2 drinks, but they could be 2 of them big bottles a day, you know what I mean? So it's really good to get, you know, for workers to know how many drinks per day people could be drinking.
Yeah. Yeah, anybody can, like I said, email Kylie. They'll send you a link. You can download it. And then once we, because if you look at apps on the internet, they tend to only have 9 letters. And so we just have to sort of make sure that whether we call it drug check or grog check or something like that, and then it'll be available on the App Store for anybody. Anywhere, I suppose, to download. But you know, yeah, you're right. It is about trying to work out, because I might sort of say I've only had 2, and as that was a real story, by the way, but with that client going in the Redfern Medical Centre. And yeah, once you realise what they were drinking out of, you realise that they were drinking in excess of the national alcohol guidelines.
Okay, thank you. I'm going to open up to the panel now, but I wanted to invite Wendy. Wendy, did you want to speak first or add anything before I start with the questions that are in our Q&A?
Yeah, with the thing, I'm just worried about with really remote areas, if they unpack that they've got a problem, to make sure that we've got correct support for them to be able to engage, because it's very hard to engage a lot of services out there, and it could be very triggering finding out that they've got an actual problem because it's been their norm in their community for so long.
Good point.
Yeah. Obviously, with you know, with the app, we try and make it as relevant as possible. So people, you know, want to, you know, if you're seeking help, we try and give people access, you know what I mean, like websites, phone numbers, etc., for the relevant, whichever state or territory you might be from, that people might be able to get contact. I forgot to mention also that once you select that you're a female, you do actually towards the end get a whole range of other questions about fetal alcohol spectrum disorder as well. The men do as well, but not as detailed as the women.
That's really good. The men still do get, the questions about the fetal alcohol syndrome, because I think, I know it's women's business, but I think it's important that men, it's also men's business as the fathers, yeah. So do anyone want to add anything before I dive into these questions? Because we've got 2 questions, and I've seen two questions have already been answered. First question, can anyone in Australia use the app? And if so, how would you work with someone who is not based in the area of work? Also, do people need to disclose their name, or can they be anonymous?
Is that for Raechel or me?
I'm not sure. I would be both. Like, is it anonymous for both the apps?
Yeah. Basically, ours, we don't need your name or anything like that. Like I said, you download it to you know, if you're just doing it for your own personal interest, then you're not putting your name. Even if we were using it in a prevalence study, for example, to find out what a community consumption is, we don't need your name either. It's all confidential. So no one, not even the researchers, can work out, for example, who said what on the app.
And likewise with Wadawanti, it is completely anonymous. While we were doing the research, it was also anonymous, but we were collecting data. But we're not doing that anymore. Now that it's just freely available, people can go on and do the activities, and they can save their activity as a PDF. But once they log out and log back in, it won't be there anymore. So it's not saved anywhere, and they can do the activities again if they want. So you have to save it while you're in it. There's no data being collected.
Okay. What I like about the Wadiwanti app is that someone who is using methamphetamine and they are thinking, like they need some help. It's good for them. You know what I mean? Like it's good for them to use, they can use it in their own time, anytime and in this personal space and then choose if they want to continue on and get any more help. You know what I mean? Like all the resources are there to support. I've got another one. These apps would be invaluable to assist in my role supporting First Nations people with substance use worries. Oh, via telehealth. So anyone got it? Anyone got any comments around, using these apps, but then their worries around telehealth?
No, I think that's true. I think they could be really useful, because obviously they can be used on a computer. So that sounds great. We haven't used it in that way. We didn't trial it in that way, but I don't see any barriers to doing that.
Okay, we've got another question. The question is around options within apps. Is there an option for gender diverse mob that identify outside of female and male? Also, is there options in the apps around LGBTQI A+ SB aspects for queer mob?
Raechel?
Well, hopefully it's inclusive for everybody. We don't address gender or sexuality in the app itself. So there's we would certainly hope that it's inclusive for everyone.
Okay.
Yeah, we would hope ours is to us as well. But as I said, we can adapt the app itself for any group or setting. For example, I've been asked to come to New Zealand later this year to sit down with Maori people to sort of get the app to be adaptable for Maori use, and it just means basically putting in what their language is, for example, and what the alcohol and slang and all of that they might use, and then let them have the app to adapt and modify for whatever use they want to use it for.
I'd certainly say I'd love feedback though. I mean, it would be great to look at it and ensure that it is, inclusive, use of language, etc. It would be great to get that feedback.
Yeah, same.
We have another one. How do these tools work alongside or connect people with real services like detox and rehab?
Well, from my perspective, because we do run rehabs and things like that across the state, it could be used as a screening tool because before you were coming in, and therefore it could give us without actually you having to fill out a form or somebody having to sit there with you to do a referral. You could use the app. You could then send us the A4 piece of paper that sort of will tell us that you're dependent or not. But, one of the things that we were able to pick up, for example, is everybody might see the mob that are sitting in the park or wherever seem to be on drinking all the time, and everyone thinks, oh, they're all alcoholic or dependent, right? In actual fact, when we were using the app, we found out that a lot of the people that were sort of classified in that alcoholic or whatever weren't actually in that category anyway. They were opportunistic drinkers, i.e. they ran into you down the road. They didn't have a lot of other things to do, and so they got on the grog. But when they had things to do, in actual fact, if you looked at how much they were drinking over a period of time, they were drinking within the standard guidelines. Unfortunately, when we come together sometimes, we're getting right into it. We were drinking at huge amounts. So to me, it could be an assessment screening tool anyway.
Yeah. following on from that, I want to ask Wendy, because you work in the centre of Sydney, CBD, how do you think these tools would work with you, with your clients?
I think they'd be working great because we're around them and with our ongoing support. But I was wondering if there's something in the app that, like, if they felt like they needed to speak to somebody, that somebody would contact them off an app too, because to me, it's just like it's a great screening tool, and I'm not trying to put anything against it. It's just to make sure that we get it right so people get the correct help that they want. And like these people in remote communities really need this app. I think it'd be great. But I was wondering if they typed in, could we please speak to somebody or something into the app, that they'd get a response so they could get further support.
Yeah. What we hope, obviously, is that, you know, any of the AMSs that you might go to down the track will have that there. And while, like I said, while you're waiting to see your doctor or your health worker in the waiting room, they give you the iPad or the tablet or whatever. You could fill it out, and by the time you get to, you can email, for example, that to your health worker doctor. Then that gives them a bit of a history of your alcohol or drug consumption. And already, you know, when you walk in there, they're prepared to sort of, they know what your history is. They can then sit down and say, well, look, you know, are you thinking of cutting down, or do you need help, or et cetera, et cetera. Rather than, as you probably know, sometimes people might not think they have a problem, because as somebody else said, everyone else around you might be doing exactly the same thing. And so it becomes almost normalcy. You know, I remember when my lawyer said, oh, Scott, you should go and do something about your problem. And I'm thinking, what problem, right? Because everyone around me was drinking or drugging at the same time. So I just thought that was just part of, you know, normal. Yeah. So yeah. You could factor that in as well.
Thank you.
I want to say sorry, Wendy. After you started speaking, I noticed your hand was up and I missed that earlier. But
No, I only just put it up.
Oh, okay. But there is a question: where do you see the greatest opportunities for digital health interventions in the future for First Nations communities?
I think it's a great tool because not even just people with addiction, families that have got questions around maybe family members that might be using and drinking, and they're thinking that it's becoming a problem. It's going to be a great way for them to see and get the knowledge on how to help them too. So it's a big thing for the whole of the communities that it's going to be across, because unfortunately we'd like to have the big drug services and alcohol services everywhere, but they're not. But by having this screening tool, it's going to help mob and families all across the board.
Yep. Thank you, Wendy. I think we're getting close. We've got one more question. Is it accessible for people with cognitive impairments?
I suppose it would be, considering that, you know, like I said, it's not me telling you about, you know, you can just either whack some headphones on and, like I said, you've got a male or a female talking to you about the questions. So, or if you're living in a remote community where language is spoken, not necessarily English, it is in language. We chose, as I said, we chose Pitjantjatjara, because, you know, we're in South Australia, but obviously it's one of the largest languages spoken in South Australia, bottom half of the Northern Territory and WA. But we could have chosen any language, right? And we could still do that. So, for example, if people from Cape York wandered in Torres Strait Islander, for example, we could do that. The fact that you've got people talking to you, I think, makes it a lot easier for people who might have cognitive issues to sort of, be able to sort of at least understand what they have to do, etc., as they're doing the. But again, if you're using it in a healthcare setting, for example, an AMS, you've got health workers there that can help. You know what I mean? Like, who could help that person navigate or understand if they don't what the question's asking them for, or they're got an NDIS provider or support worker. It's nothing. I can't see why they wouldn't be helping them anyway.
Okay, thank you. Oh, we're going to have to wrap it up. It's 1 o'clock, and I had another question, but it's 1 o'clock. So I want to thank you, Raechel, Scott, and Wendy, for being on this panel today. And thank you all. Thank you all for watching.
Thanks
Thank
so much.
you.
Thanks for having
you.
Thanks for inviting us.
Thank you. See you.
See you.
Bye-bye.
Bye.
Bye.
Bye.